Okay, next we're going to talk about platelet disorders. Platelet disorders we're going to talk about are disorders associated with a decrease in the number of platelets known as thrombocytopenia, or even in the decreased functioning of platelets that predisposes patients to bleed. Like all platelet disorders, patients are initially going to present with signs of bleeding from superficial areas of the body, such as skin, the nasal mucosa, the oral mucosa, the GI tract, the urinary tract, as well as the vagina. Now, if the PT is normal and the PTT is normal and platelets are decreased, we know it's going to be a platelet disorder. Now, basically, if the patient has epistaxis, petechiae, bleeding gums, as well as vaginal bleeding, you want to start thinking of a thrombocytopenia, and you want to start thinking of ITP, idiopathic thrombocytopenic purpura. Okay? And basically, in ITP, there's going to be a severe thrombocytopenia associated with a platelet associated IgG antibody, and it's going to be a diagnosis of exclusion. So basically, your DIC panel here is going to be negative, and these patients are usually going to be young patients. It occurs a little bit more in the female population, and they're going to have the superficial type of bleeding. The patient is generally otherwise going to be healthy, and one finding that you want to remember is that splenomegaly is going to be absent, as well as a negative DIC panel. So these patients are going to have antiplatelet antibodies, and their peripheral smear is going to be normal, okay? And they're going to show a bone marrow that's going to be filled with megakaryocytes. And when you have a bone marrow filled with megakaryocytes, that indicates that there's going to be a problem with platelet destruction and not a problem in platelet production. So basically, the bone marrow is going to help us exclude other causes of thrombocytopenia, such as cancer, such as infections that can cause thrombocytopenia, like tuberculosis and fungi. Chemotherapy can a lot of times cause thrombocytopenia, as well as drugs. And basically, if the bone marrow is filled with megakaryocytes, that means that there's a problem with platelet destruction and not a problem with platelet production. And the destruction is due to antiplatelet antibodies. So we've made our diagnosis of ITP, and basically, if our patient has a platelet count that's less than 50,000, our treatment is going to be steroids. And basically, prednisone is the steroid that we're going to use. And if the patient has a platelet count over 50,000, you're going to do nothing to this patient. Okay? If the patient has a life-threatening bleed, such as a bleed that occurs in the brain or the bowel, you're going to do IVIG, or you're going to give ROGAM. If there's recurrent bleeding after you give steroids, splenectomy may be used. So splenectomy may be used in recurrent bleeding after steroids, or in patients who have a really low platelet count, less than 10,000 or 20,000, and you continually use steroids and steroids don't work, okay? And basically, if it's life-threatening, you're going to go IVIG or ROGAM, and it's going to be usually the patient with less than 10,000 with the risk of a life-threatening bleed. You have to remember that ROGAM can only be used in RH positive patients, and this is why it's not considered a first-line therapy, okay? Patients that are refractory to ROGAM can actually use rituximab. Next, we are going to talk about this cluster PT that's normal, PTT that's normal with a decrease in platelet count. This can occur secondary to thromboses. And if you have a drop over 50% of the platelet count after several days of heparin use, we're gonna think about heparin-induced thrombocytopenia in the stem of the question. And one thing that we actually use to prevent the heparin-induced thrombocytopenia is we give heparin and warfarin together. We don't give warfarin a couple of days after heparin. We actually give heparin and warfarin together because the warfarin actually helps prevent the heparin-induced thrombocytopenia. But heparin-induced thrombocytopenia is an immune-mediated thrombocytopenia, and it usually occurs 4 to 14 days after the initiation of heparin. Basically, what you're going to use to confirm diagnosis is platelet factor 4, also known as PF-4. And basically, these are going to be serotonin release assays from platelets, which are also used. The platelets are going to release labeled carbon with serotonin. So your two tests are platelet factor 4, also known as PF4 antibodies, as well as serotonin release assay from platelets. You've made your diagnosis of heparin-induced thrombocytopenia. What's going to be your first step? It's going to be stop all heparin immediately, and you're going to use an alternative such as Heparin, argatroban, or dinaparoid sodium. Dinaparoid sodium is another one that can be used. Okay, you have to remember some of the trick distractors you may see is switch to low molecular weight heparin. Absolutely not true. Warfarin is going to be your wrong answer. Your right answer for heparin-induced thrombocytopenia is Heparin, argatroban, and dinaparoid sodium. And this is going to go over the coagulation cluster of a normal PT, a normal PTT, and a platelet count that's decreased. And this is going to be our most important platelet disorders that we want to know. We want to talk about.